2019, we were launching United Cancer Centers, or we're raising money for United Cancer Centers in the United States. You had a model that, like I say, we weren't ready for yet because I didn't exactly understand it. It takes a minute, you know. I'm not a trained scientist like you, but you know, we were very much we were patient focused at UCC. We were going to be the first institution to utilize the right to try legislation, and you wanted to take it a step further, where we had our own genomics labs. We were doing our own pathology. I think either you or VJ brought on the digital pathology, but the idea was to get as much information as we possibly could from the patient's tumor, and then deliver precision medicine to the best of our ability and build out the labs with UCC. Now, at the time, I knew a little bit about genomics, like just very, very basic, but hadn't really dove in. And I'm like, oh gosh, I don't know how we'd put all that together. But as COVID happened and that project ended up not happening, it's like, there's an opportunity to do that, you know, in Mexico, and even be able to have more freedom to do more.
Right.
Like my question with the solid tumor genomics lab is, how do we build the best solid tumor genomics lab on the planet, at least for the patient specifically? There's other places that'll have our capabilities, but is it going to be centered towards what the information the patient needs, either now or in the future? Right now, there's going to be discoveries on the tumor that we can't really take action on. But in a year, 2, 5 years from now, you know, there's that possibility. So I like to say that a lot of the idea for what we're doing now came directly from you. You know, this was part of your vision for what we were doing, and you know, I say that because the earpiece is another. Well, I say the earpiece, the project that you have with the earpiece and the pregnant women is another part of that, because the model that we're creating in Mexico, we're going to bring to Nashville. We have the potential to ask questions in a completely different way and focus on these underserved communities to make a huge impact. And you can do that without a lot of money. I mean, it doesn't take a ton of money to, once you understand how to build the labs and run the tests and what tests to run and, you know, how many samples you need before you can run the machine at a cost-effective way. There's ways that for a small amount of money, you can get a lot of meaningful information to patients on the cancer side, but also just on the overall life side. And kind of elaborate on that, because I don't think people realize maybe that's what we're talking about in the whole. Like, this is an ecosystem that you're putting together based on how to solve complex diseases and how to really make the world a better place or a healthier place for everyone.
Yeah, and I guess there's sort of two examples for that. One is, as an example, there's a lot of emphasis right now on social determinants of health. And they're important. There's no question about that. But I think a challenge that we haven't necessarily adopted or acknowledged is, to a certain extent, we're looking from the outside in and trying to make an assessment of where certain characteristics, features should be, could be and should be. You know, is it an educational problem? Is it an access problem? Is it a smoking problem? Things of that nature. We also need to expand upon that, which is something we've been doing, and say, that's from the outside in. You need to understand it from the inside out. Because if you really want to be patient-centric, and especially if you're going to be dealing with multiple cultures, they don't look at the world the same way you do.
Right.
And you need to understand how they look at the world, because your priorities may not match their priorities. And as much as you can explain it, they may not accept it and act on it.
Sure.
And so it needs to be an interface between the two. And then even with several cultures at least, you need to understand the concept of trust. Are they going to even trust what you're telling them? Because the simple examples in trust are, do they have confidence that you know what you're talking about? And do they have confidence that you're looking out for them, not for some other purpose?
Yeah, absolutely.
And all of these things come into play that make the problem more complex than even just looking at the social determinants. But that's what the real world is about, and that's what a real patient is about.
Absolutely.
And so we need to keep those things in mind. On the other hand, again, with the technology, as I said before, we take advantage of the technology we can develop and then try to use it to look at disease. I'll give the example I'll use is when I was at Vices, we were working on the HER2 new test using fluorescent in situ hybridization, or FISH. That measured gene copy numbers. That was different from the immunohistochemistry test, IHC, which looks at an antibody response to a protein. And yet both eventually were approved for use for looking at what they call HER2 new positive breast cancer patients, which are about 20% of the patients. The challenge was they don't give you the same answer necessarily because they're not looking at the same thing. And we have to understand that biology is complicated. So going from the copy number of the gene, which ties to the chromosome, to the protein, there's multiple steps and transformations.
Yeah.
And it may be that those transformations are the critical thing, and we're only looking at the endpoints. And by not looking at the part in the middle, we're missing what really is important. And the suggestion that that could be a reality is we're no longer looking at HER2 new positive and HER2 new negative. We're also looking at HER2 new low. So we've started to increase the classifications.
Yes.
And that shows you, at least that science is continuing to evolve, but it evolves very slowly because the tendency is to try to come up with classifications and put things into boxes.
Yes.
Whereas the real world doesn't really like that.
Yeah. And a couple things. I want to actually go back from the copy number to the protein and go through that system. But, you know, what you're talking about with HER2, I feel like I have a good amount of experience with. I've seen it in action, right? And I shared with you a case. We had a patient, I'll just share with the listeners, had a patient who metastatic cancer. It was a stomach cancer, didn't know exactly which type of stomach cancer. They were at a specific hospital. A friend contacted me. She hadn't eaten in weeks. She was emaciated. He said, "Hey, can you help her?" I said, "Let me see if I'll give it to our doctors and see what they think." Got back to him pretty quick, and it's like, she might pass in the hospital within 7 to 10 days. So we've got to be, you got to know that, set that expectation. But we'll give it a try. Well, she gets in, and the institution that she was at is a great institution. It's like 1,000 pages of medical records or so. It's like and we started digging in and noticed that a genomics test had been ordered, on the tumor, and it had not been put in the system. And so we called the next day, and they sent it right away. It had an actionable marker, HER2, and we'll get into the HER2, what you're talking about, low or regular. But within a week, she was eating. Within 2 months, her cancer was gone, not cured, but you couldn't see it in images, couldn't tell it through blood work. And it turned out she had a specific cancer that's what's called CDH1 positive. And it's a stomach cancer that you have about a 75% chance of getting this stomach cancer if you have the CDH1, and they recommend if you have it that you get your stomach removed, and which is it's a big deal to do. But she got it right at the age that most people get it at, and lived a couple years. But that's one specifically where we had a target that the HER2 worked well,
Right.
and there was a good outcome.